Okay, so the proposed study will be titled The Efficacy of Postoperative Upper Extremity Rehabilitation Following Breast Cancer Treatment, PT Promote Trial. Okay, so the outline of today's presentation will be the background, the purpose of the study, the significance, the methods, and the study interpretation. We'll start with the background, which will address the current problem, as well as a brief literature review. Okay, so here's a graphical representation of this. On the y-axis, you have the rate per 100,000, and you can see the incidence and the mortality trend lines as shown. You can see that over time, there's an increased incidence and an increased survivorship. The increased survivorship is obviously good. The issue is that these women are then left with chronic physical pain, decreased shoulder function, fatigue, weakness, decreased range of motion as previously specified. So you have this increased disability, and there's more people that are going to have this disability because of the survivorship. And the issue at hand is the fact that the translation of research to clinical practice is missing. There's a need for optimal individualized rehab interventions and parameters. The pre-surgical, the post-surgical, and the long-term surveillance of this rehab is not well defined. And this is the problem that needs to be addressed. So when you look at the literature, there's been over 19 systematic reviews to date, and it's clear from these that rehabilitation for post-op breast cancer is shown to be safe and effective. There's also a need for high-quality randomized controlled trials to determine optimal manual therapy parameters and techniques as a part of a multimodal post-operative rehab program. Further prospective clinical trials are warranted. And they're warranted because we need to bridge the gap between rehabilitation research and clinical practice, the dissemination and the implementation of available research findings, establishing a systematic way of providing individualized rehab, and defining optimal care across the disease process. So the American Cancer Association came out with the prospective surveillance model for rehabilitation of women with breast cancer in 2012. And you can see how I've kind of laid it out here. So you have the diagnosis, the prehab, the surgery, the post-operative rehabilitation, which this presentation and this study will focus on, and then you have the ongoing survivorship. The formal definitions and labels for each of these phases are the breast cancer diagnosis and treatment planning phase, the post-operative period, and then the adjunctive treatment and survivorship care phase. Okay, moving on to the purpose of this specific study. The overview of the study will be the first in a series of trials labeled the Postoperative Physical Therapy Protocol for Optimal Management of Shoulder Limitations, also known as PT Promote. The rationale for targeting the postoperative phase is that physical disability is the greatest. Rehabilitation and exercise demonstrates to be safe and effective at this time point. You have the potential to mitigate future sequelae that would otherwise result from a delayed onset of care. And the initiation of physical activity and exercise at this time point has the best opportunity to promote and facilitate an active lifestyle going forward into the survivorship care phase of the PSM. The study design will be a prospective pilot trial, one-way repeated measures. The setting for the surgery will be at the Stanford Women's Cancer Center in Palo Alto, California. Rehab will take place at Stanford Healthcare's Orthopedic and Sports Medicine Physical Therapy Clinic in Redwood City, California. The intervention will be a criterion-based postoperative protocol that will last 12 weeks, 13 sessions. Each session will be one-on-one with a therapist and last 45 minutes. The purpose of the study is to test the efficacy of a postoperative criterion-based tissue healing phased rehabilitation protocol to improve the quality of life and the upper extremity function of adult women seen post-breast cancer surgery. This includes breast conservative therapy, such as lumpectomy or mastectomy. The protocol will use a combination of replicable manual therapy techniques and exercise interventions to optimize the recovery of upper extremity disability and secondary impairments that results. Moving on to the significance of the study. So here's the stated problem as shown previously. And the clinical relevance and significance of the current study is that it will implement current research into clinical practice with the consideration of individualized care, respect for tissue healing timelines, using a criterion-based progression. Moving on to the methods. So this will cover the research questions, the hypotheses, participants, instrumentation, the procedures, as well as the data analysis. The PICO components of the research question are outlined here. This will include females ages 18 to 65 years of age, seen post breast cancer surgery. The intervention will be a 12-week, 13-visit, phased, supervised, and home-based protocol, including both therapeutic exercise and manual therapy. It's a pilot trial with no comparison. The primary and secondary outcomes are listed there. The health-related quality of life will be BrCa 2.0, Fact B. The disability will be measured by DASH. The shoulder active range of motion and passive range of motion will be also part of the primary outcomes. Secondary outcomes will include pain at rest and with ADLs, and then grip strength and isometric strength of flexion and external internal rotation. The time point will be 6 months. The hypotheses of each of the dependent variables are outlined in the table below. So you have the dependent variables in the first column, the null hypothesis, which is essentially is no change pre and post for all of these dependent variables. And the alternative hypothesis is improvement in each of these outcomes pre and post intervention. You'll notice that a couple of them are bolded, indicating that there's actually going to be a decrease from the pre to the post time points. However, given the construct, that decrease would actually indicate a measurement. Otherwise, we'd expect all the other ones to increase. Taking a closer look at the inclusion-exclusion criteria, we'll be looking at females ages 18 to 65 years of age with bilateral or unilateral breast conservative therapy or mastectomy. Post-time point will be 2 weeks to 6 months with axillary cord syndrome or not, with or without chemotherapy. The exclusion criteria is listed here, including adhesive capsulitis, prior shoulder surgery on the involved side, lymphedema as measured by circumference measurements of the upper extremity and a difference of 2 centimeters from side to side at different specified locations, active infection, fracture, neurological deficit, previous breast cancer treatment, stage 4 breast cancer diagnosis, pregnancy, benign tumors that don't classify as breast cancer, severe pectoral contracture / breast capsulitis, and radiation therapy. The sampling of the current study will be of convenience from 3 physician practices. The process will be that potential participants will be identified by the physician's assistant or medical assistant of the above physician practices and will be based upon the inclusion and exclusion criteria previously specified. The instrumentation is shown here. So you have the different constructs that will be measured, and then you have the instruments in the right column. So we'll be looking at the health-related quality of life, subjective upper extremity function, pain, range of motion, and strength of the upper extremity. Okay, so you have these 2 bodies that we've introduced, the Academy of Physical Therapy Research, as well as the American Cancer Society's prospective surveillance model. And both of these bodies endorse these instruments to be utilized to measure these constructs. Furthermore, both of these bodies recommend that these constructs actually be measured within rehabilitation literature for the breast cancer demographic. Okay, looking at health-related quality of life, the BrCa 2.0 has good to excellent reliability and validity in measuring the health quality of life and patient satisfaction of the current study population. The same can be said for the functional assessment of cancer therapy for breast cancer, also known as the Fact B. Each of the subscales of the Fact B have shown to have good to excellent reliability and validity for the current studied population. So disability and pain, so the DASH is consistently shown to be the patient-reported outcome that has the most consistent large effect sizes for construct validity and responsiveness in breast cancer survivors. Additionally, the VAS pain scale demonstrates excellent psychometric properties, clinical utility, and consistently is used in clinical trials studying individuals post-breast cancer and their pain experience. The calibration for the inclinometer will be done as described within the manual provided by the manufacturer. It will be done using standardized angles before the study, and the measurement error would be plus or minus 1 degree. The digital inclinometer is shown to be a reliable and valid measure for shoulder passive and active range of motion within the studied population. Prior to the initiation of the study, the annual calibration of both the hand grip dynamometer and the handheld dynamometer will be done according to the manufacturer's instructions. Both instruments have been used in prior clinical trials assessing the treatment outcomes of breast cancer survivors. They have excellent psychometric properties and clinical utility in the breast cancer population, and both are endorsed by the APTA EDGE Task Force as well as the ACA's PSM model. Okay, moving on to the procedures, starting with recruitment. So it will be a sampling of convenience, as previously mentioned, from 3 MD practices. The individuals will be deemed eligible by the inclusion and exclusion criteria. Those that are deemed eligible will then go through an informed consent, which will include the study design, study details, risks, and benefits. And you can see that this takes place after the diagnosis, but before the surgery. The second step in the procedures is the informed consent itself, where the patient will be informed about the risks of participation, which include confronting the fear of using their involved upper extremity, physical exerting themselves with stretches and exercises, physical and emotional fatigue whilst still recovering from the surgery and perhaps chemotherapy, transient increases in physical pain during gentle and progressive manual stretching of the arm and or shoulder, and musculoskeletal related adverse effects from resistance training, such as muscle strain and or joint pain. After signed, the informed consent will be securely and confidentially scanned into the electronic medical record, which is HIPAA compliant, and the hard copies will be shredded. Step number 4 will include the derivation of the protocol, which includes a literature review, a drafting of the protocol, and a peer review of the protocol by oncology certified physical therapists. Additionally, we'll need to train the therapists who are administering the treatment. This will include an online training module and a post quiz for the 4 therapists. This will include the benefits and the risks of the study design, the interventions involved, and how to administer them. Additionally, the participants will be randomly allocated to different therapists to control for the effect of one therapist's outcome versus the next. Step 6 will be the implementation of the intervention. Physical therapy will be initiated during the 4th week post-surgically. All physical therapy sessions will be 45 minutes in duration, 2 sessions for the 1st week, 1 session thereafter, and the home exercise program will be prescribed via handouts as well as an online portal. You can see the visualization of the timeline here: surgery, then 3 weeks of relative immobilization, and PT will be initiated that 4th week and continued 12 weeks thereafter. Number 7 is data collection. In the first column you have the dependent variable, and then in the subsequent 5 columns you have the respective time points at which each of these dependent variables will be captured. This is indicated by the X's. The patient-reported outcomes will be captured via HIPAA-compliant REDCap software that is done in clinic. The physical performance measures will be recorded within the EMR as well as in a Microsoft Excel spreadsheet in clinic. The Excel spreadsheet is only accessible through medical institution intranet, requires a password to log onto the computers, the drive itself is encrypted, and only department personnel can access it. Furthermore, the Excel document itself will be password protected. The order of each physical performance measure will be randomized at each collection time point via the Microsoft Excel randomize function, and this is to reduce the influence of one measurement on the outcome of another. The shoulder range of motion, the grip strength, as well as the shoulder strength will be tested in procedures that are replicated from previously described breast cancer intervention studies. For the grip strength and the shoulder strength, a mean of each of the 3 trials will be used for data analysis. The data analysis itself will be done via SPSS. The pre and post test comparisons for the dependent variables, again shown there, will be done via a repeated measure and COVA. The effect size via a Cohen's d analysis will be done pre and post 13 weeks interventions for both of the patient-reported outcomes and the physical performance measurements. Additionally, the patient-reported outcomes that are taken at the 6-month time point will also have an effect size calculated to it. The statistical significance will be determined by 95% confidence interval with an alpha of 5%. Okay, moving on to the study interpretation, strengths and limitations. Okay, so strengths of the current study is that it bridges the gap between clinical research and clinical practice. It reveals areas of improvement and barriers to the feasibility of the current protocol. It will provide foundation for future randomized controlled trials for the early postoperative phase. It also provides initial steps in defining optimal dosage and interventions of the early postoperative phase of the American Cancer Society's PSM model. So the limitations of the current study are the study design, a pilot trial with no control group or randomization, limited inference of causality, sampling of convenience, single-centered trial, which reduces the generalizability of the findings and the outcomes. The participant selection is susceptible to heterogeneity. Unknown what clinical factors increase the risk of upper extremity disability. This will require a secondary analysis to better identify subgroup of participants of future studies and stratify the necessity of physical therapy services based upon the breast cancer treatments.